6:45. Yep. Good morning, everybody. I'm Howard Chansky. I'm the chair of the Department of Orthopedics and Sports Medicine. Welcome to our May 2022 Grand Rounds. A couple of brief announcements before we start. The first one is kudos from Anita Thomas, who is an attending in the emergency room at Seattle Children's Hospital. And she was noting that Dr. Max Cole, one of our residents, was nothing short of phenomenal on the evening she worked with him. She had already heard from other faculty and fellows that Max was great, and she noted that he certainly lived up to his reputation. Dr. Thomas said that Dr. Cole had an excellent rapport with families and was very appropriate with patients. He was super responsive, friendly with consults, and I encouraged him to consider pediatric orthopedics as a fellowship. That's really great, Max. Thank you. The other one was a note that I received from Barbara Young. Dr. Young is the chair of the Department of Medicine, and Eli took care of somebody, I will not go into the details, in Dr. Young's family. And Dr. Young said that he had done a spectacular job. And I can attest from firsthand experience what a great caring Dr. Eli is. So thank you for that. With that, we'll move on to Grand Rounds. And we have Dr. Matt Vincent partnering with Dr. Viral Patel. And they are going to talk about what I think is a pretty hot topic right now, and that is cervical disc arthroplasty. So thank you. Dr. Vincent, are you going to start?
I sure am. Okay. All right, thank you, Dr. Chansky, and thank you everybody for tuning in. I am Matt Vincent. I'm one of the R3s in the UW Ortho residency. Today, along with Dr. Patel, we'll be discussing the latest developments in cervical disc replacement. How do we avoid a pain in the neck? I have no disclosures. A brief overview, we'll be talking, of course, about the anatomy, basic science, and biomechanics of the cervical spine, pathophysiology, a history of the surgical treatment, the rationale for motion sparing with the subsequent development of cervical disc replacement, complications, and then Dr. Patel will go over technique and case presentations. So if you'll indulge me for a second, I find it helpful to think about orthopedic problems from the evolutionary perspective. As the only obligate bipedal mammal, humans have an orthograde spine, meaning that the force of gravity acts in parallel to the vertebral column, in contrast to our four-legged friends, in which the force of gravity acts perpendicular. This means that the cervical spine then sits atop the vertebral column and controls the balance of our head and our head movement. This allows for increasing our field of vision, our interaction with the world around us, and stabilizing our head during locomotion. Taking a closer look at the anatomy of the cervical spine, we'll be focusing today primarily on the subaxial cervical spine, given the topic at hand. The cervical spine, of course, has smaller vertebral bodies, has relatively horizontal facet joints, usually an angle between 20 and 70 degrees, compared to the more vertical thoracic and lumbar spine. Between each vertebra, there are 5 points of contact. There's the intervertebral disc, the two zygapophyseal joints or facet joints, and then unique to the subaxial cervical spine, the two uncovertebral joints, where the uncinate process articulates with the vertebral body above. This is particularly relevant for our discussion today, as this is in close proximity to the neuroforamen and can be a site of osteophyte formation. There's also the ligamentous structures that stabilize the spine, of course, the anterior longitudinal ligament, the PLL, as well as the posterior ligamentous complex, including the facet joints, and then particularly relevant for our discussion today, the ligamentum flavum, in addition to other ligaments. Motion in the cervical spine is a little more complex than one may initially think. Of course, we know the upper cervical spine is responsible for a significant portion of our rotatory movement. About 50% of the rotational ability of the cervical spine occurs between the occiput and C2. Flexion extension is largely done in the subaxial cervical spine. The unique biomechanics of the cervical spine place the center of rotation of the vertebral bodies at different locations, depending both on the plane of motion. So in the sagittal plane, it's different than in the coronal or axial, but also in different phases of motion, meaning that the center of rotation in early flexion is different than late flexion, is different than early extension, is different than late extension. In this in vivo study of the motion of the cervical spine vertebral bodies and their relative centers of rotation with an MRI protocol, you can see in the sagittal view, the center of rotation is actually quite inferior. Looking at the, for example, C3 center of rotation, that yellowish orange dot, it's actually in the middle of the body of C4, well below the intervertebral disc space. The center of rotation changes throughout the cycle of motion. I've pulled out some of the tracks of that on the right here. That's C3, C4, and C5. It's a little hard to see the units here, but that's actually over a centimeter of difference between the different points of flexion extension. This is a highly dynamic process. Looking at the coronal plane is a little bit simpler with lateral bending. The center of rotation does tend to be either just at the bottom or in the middle of the vertebral body. Compare that again to the sagittal plane, you can see the pretty significant difference in the location of the centers of rotation. This means that an attempt to recreate the natural motion of the cervical spine has to go far beyond just a simple hinge joint. Again, rotation is largely accomplished in the upper cervical spine and limited to 1 to 5 degrees per level in the subaxial. We'll be talking today a lot about the intervertebral discs. As a brief reminder of the anatomy, these are constituted by the nucleus pulposus in the middle, made up primarily of type 2 collagen, which is bound to these water-saturated proteoglycans. They're constrained and surrounded by the lamellae of the annulus fibrosus, and both are anchored to the cartilaginous end plates through which nutrients diffuse, as the intervertebral discs, especially in the lumbar spine, are the largest avascular structure in the body. What this does is it converts an axial loading force from the vertebral column into a hydrostatic pressure force that is then constrained and cushions that compression. Over time, the cervical discs degenerate. This is just a simple process of aging where you have an increase in the ratio of type 1 to type 2 collagen, which results in an overall decrease in the water content. You can see in this staining of a healthy and degenerated intervertebral disc, the significant change on the ratio of type 1 to type 2 collagen. In the MRI studies below, you can see the gradual decrease in water content shown by the loss of T2 signal intensity, as well as the thinning of the overall disc space. This is part of a larger degenerative process, cervical spondylosis. What happens is as these discs degenerate and become desiccated, it changes the way that that force is distributed. No longer does it convert that axial into a hydrostatic force, and instead that's borne more by the 5 points of contact between the vertebral bodies. Again, these become a locus for regional inflammation and reactive bone formation, in addition to the different pathologies associated with disc bulging, herniation, and thinning. You can see the normal cervical lordosis in the lower left here. Over time, this starts to convert to a kyphosis due to the asymmetric loading of the anterior aspect of the disc. This is a vicious cycle as the loss of lordosis creates more force in the anterior part of the disc, which then creates further loss of lordosis, and it becomes a cycle that feeds on itself. In this combination diagram on the right here, you can see some of the later effects of cervical spondylitis, as we will discuss later. You see the formation of osteophytes at the edge of the end plates, typical beaking around the sides there. You see hypertrophy and eventual ossification of the ligamentum flavum, posterior longitudinal ligament, both of which can then decrease the space available in the spinal canal. See overall reshaping and then the loss of vertebral height of the cervical discs, the cervical vertebra, and then eventual compression of the spinal cord. Like I said, cervical spondylosis is a natural degenerative part of aging. If you look at imaging studies of just the general population, Once you reach the age of 40, a majority of people will have imaging findings suggestive of degeneration. And when you hit 60 years old, that number is nearly 90%. In fact, disc protrusion that creates imaging appreciable cord compression is present in 8% of asymptomatic older adults. This is just to drive home the point that the imaging does not necessarily dictate the pathology. So what happens when this degenerative process then becomes pathologic to the spinal cord? We get our cervical spondylotic myeloradiculopathy. There's a combination of the classic symptoms that your patients will show up in the clinic. As residents, we see them when they walk in. They'll be complaining of radiculopathic symptoms, the shooting pains, numbness. On our exam, they may have a positive Sperling sign. They may have myelopathic symptoms, a loss of coordination or balance in the lower extremities, difficulty with controlling their bowels and bladder. This can result in those positive long track signs, Hoffman's, Babinski's, and Romberg's. Commonly associated, but not necessarily dictative of myeloradiculopathy is axial pain. This, of course, is a result of that local inflammatory process that occurs as part of spondylosis. And then the progression of these symptoms occurs in a classic stepwise manner and eventually leads to spinal dysfunction. In fact, it is the leading cause of spinal dysfunction globally. On the right here, you can see a standardized scoring from the Japanese Orthopaedic Association of myeloradiculopathic symptoms. This is used as part of the AO spine guidelines to determine the indications for surgery. So you have a patient who presents with myeloradiculopathy. What do you start with? Well, most orthopedic problems, we start with our non-surgical interventions. Activity modification, especially exercise, is very important to the treatment of these patients if they're able to. Physical therapy is a huge part of our non-surgical intervention. Appropriate physiotherapy done over an extended period of time in some studies has been shown to be non-inferior to surgical intervention. Once we move on to medical therapies, we'll be using primarily oral analgesics and anti-inflammatories, things like NSAIDs over the counter. Our non-surgical but still procedural interventions include the epidural spinal injection. This is helpful both as a therapy and a diagnostic tool. While it can provide relief of the patient's symptoms, it can also help identify the appropriate cervical targets for us to then approach with surgery. Intradiscal injections are a more controversial aspect. There are both viscosupplementation as well as stem cell therapies, all under extensive research, but have yet to bear out encouraging long-term results. So you've tried non-surgical interventions with your patient. They've been able to put off surgery for a while, but at what point do you then pull the trigger and say that we need to operate? As I've tried to emphasize, we can't rely on imaging alone. These degenerative processes and changes on imaging, although correlate and help us identify the appropriate targets for surgical intervention, should not be an indication for surgery on their own. Prophylactic addressment of cervical stenosis and spondylosis has not borne out a helpful long-term care plan. Once they've failed conservative management, the AO spine guidelines recommend quantifying the amount of cervical dysfunction with radiculopathy and myelopathy and using that to base the relative indication for surgery. Operating for isolated axial neck pain is still controversial and, at least in North America, rare. The long-term benefits of simply addressing axial nerve pain without axial neck pain without addressing a neurologic dysfunction, again, not have encouraging long-term results. So you've decided that your patient needs surgery. So what are you going to do about it? If you're in the 7th century, you'll be talking with Paulus of Aegina, the first person to perform spine surgery. Modern spine surgery began in the early 19th century. The first laminectomy was performed in Kansas in 1829. The appreciation for disc pathology really came about in the mid-19th century, the first to quantify histopathologically the degenerative changes in the intervertebral disc is Rudolf Virchow, Virchow's triad fame. But throughout the late 19th and early 20th century, there was still not a connection between the pathology seen in disc degeneration and the effects in cervical myeloradiculopathy. Walton and Paul, for example, in 1905, operated on 2 patients who had evidence of compression. In this time period, most of the decompression procedures were performed for either Pott's disease, so tuberculosis of the spine, oncologic or other tumor processes, or traumatic injury. When they operated on patients for a compressive syndrome, they found these bulging tissue masses from the intervertebral space. They considered them tumors, labeling them chordomas. It wasn't until the later 1920s and early 1930s when physician scientists like Byron Stuckey finally made the connection between the disc degeneration, disc bulging and impingement, and the myeloradiculopathic syndromes. Discectomy was primarily performed through a posterior exclusive approach up until the mid-20th century. This could involve either an intradural approach, where you release the dentate ligaments to allow for better spinal cord retraction and access to the disc, or extradural approaches, primarily through foraminotomy. This could involve freeing the nerve root, sacrificing the nerve root, or entering the nerve sleeve. Of course, this all involves significant cord and nerve manipulation. And unfortunately, at the time, due to the lack of reliable fusion methods, really meant that you could only perform this unilaterally without significant destabilization of the spine. And so if you have a patient presenting with bilateral symptoms, then they have little recourse. This isn't until the 1950s. In 1954, Smith and Robinson at Johns Hopkins performed the first anterior cervical discectomy and fusions using the anterior approach to the spine that was initially developed by otolaryngologists to address esophageal pathology. They accessed the spine through the anterior longitudinal ligament. They incised over the intervertebral disc space, performed the discectomy, and then placed a tricortical bone graft block between the vertebral bodies. They did not have any fixation other than suturing up the ALL, but 13 out of their 14 patients had significant improvement. Most of them improved relatively quickly, including just a few days after surgery. And they had reasonable success with the fusion rates long term. Once this was developed, the developments in ACDF became widespread and with quick technological advancements. Interbody fusion developments. On the left here, you see multiple designs for the intervertebral body fusion grafts. The Smith-Robinson tricortical at the top, the Cloward-Dow Bailey-Badgley bar, and then the Simmons-Paula keystone graft. Eventually, in the late 80s, early 90s, there's development of the cage systems to allow for implantation of allograft and bone supplementation, which is probably what we're more used to seeing today. Fixation came about in the 1970s, starting with the simple Casper plates over on the left, the H plates on the right. These were non-constrained, simple plates that relied on bicortical fixation, which, as you can imagine, when operating in the cervical spine, is rather technically challenging. We've seen an explosion in the number and complexity of the anterior cervical plates and an improvement in the ability to contour to a patient-specific anatomy. So as the ACDF becomes more widespread and used, it becomes the gold standard for surgical treatment of cervical myeloradiculopathy. We have many randomized controlled trials showing improvement in pain, function, and both. These are comparative to both pre and post-operative, as well as placebo effects. So we have this surgery that's working well for a lot of people, but what is lost with the fusion? As I tried to emphasize earlier, the cervical spine motion is a rather complex multi-level interaction. And so changing the motion at one level is going to change the kinematics throughout the entire cervical spine. On the right here, you can see this is comparing intradiscal pressures before and after a fusion of a single level. We see effects all throughout the spine with increased force through those discs. Concerns for this were first raised in 1959 in the cervical spine by Scoville, responding to Cloud's procedure. But they didn't really gain traction until the early 1980s, when we started appreciating the pathology in adjacent segments. Again, similar to spondylolisthesis, it's important to delineate between a radiographic effect and a clinical effect. A large majority of patients will show some increased degeneration at adjacent segments after fusion, but that does not necessarily mean that they're going to have clinical manifestations. It's not an uncommon phenomenon. About 3% every year of patients with ACDF will convert to an adjacent segment disease, which works out to about 25% over every 10 years. But we still have to ask ourselves how much of this is iatrogenic. The leading risk factor for development of adjacent segment pathology is degenerative changes before the operation. So a lot of this may just be due to the natural degenerative processes that is already occurring in these patients. So when we consider these effects of the adjacent segment pathology after the fusion, then we start to think about what can we do to try and replicate the motion of those intervertebral discs. The first attempt at this was the Fernstrom ball, although this was not meant to address adjacent segment disease. This was a stainless steel sphere that was implanted between the vertebral bodies and was initially done to mimic what was conceptualized as a ball joint. And this was the first step in the development of disc arthroplasty. And to take on the rest, I'll pass it off to Dr. Patel.
Okay,
Hey, Dr. Patel, you're muted.
Yes. Thank you, Matt. Thanks, Dr. Chansky. Thanks to everybody. So I have non-disclosure. I don't know how I can do this. Okay. So I'm going to reiterate one more time why it's a rationale for preservation of the motion of the cervical spine. So initially, when all the fusion started, most of the surgeon was taking iliac crest bone graft, which requires additional operative time, and any surgery comes with a complication. So there's additional complications from it. So now the surgeons move to the PIC cage and metal cage and structural allograft instead of a iliac crest bone graft. So instead of autograft, we started using allograft, which also increased the rate of pseudoarthrosis. Then now we have to now we have a pseudoarthrosis rate that requires reoperation at the levels. So that's increased. Then also with the fusion, we lost some motion. So with the single level fusion, usually most of the patient don't feel any difference. But as you increase the level of fusions, is decreased by 7 degrees per level, which also increase the loss, increase the motion above and below, just to compensate your cervical motion. So I think it's put stress on the adjacent levels segments. So radiographically, now we are looking at the adjacent level degeneration, which is radiographically is as high as 92% was reported, but incidents are also present in a young ACDF patients who had an ACDF because of a trauma, or it also has ACDF in the older patients. So it doesn't matter how is your adjacent level. It actually has some correlation with the fusion and adjacent level degeneration radiographically. That doesn't mean you have a clinical symptoms, but that definitely increased the rate of degeneration at adjacent level. So there is a study they did in a MRI study at the 10-year follow-up with ACDF with healthy controls, and will show that increased rate of adjacent level degeneration. So this is a pioneer study by Hildebrand. He did the study follow-up with the 21 years, all the ACDF patients with 1 level and 2 level. He saw that he has adjacent level degeneration radiographically, but it was symptomatic in 25.6% patients over the 10 years. Its incidence was 2.9% annually. And out of this symptomatic patients, he required 2/3 patients required additional surgeries at the adjacent level. So I think it's important to, now we know this is the whole scenario started, why we need the surgery was a decompression of the spinal cord and the nerve, and we need to maintain the disc height and the stability of the spine. Fusion was just maintaining its height and stability. But if you find another way to maintain the stability and the height, in addition to the decompression, which is the first goal of the surgery, then I think if we can prevent some adjacent level degeneration. So that was a whole rationale for motion preservation. So this is how it started. Matt already mentioned is they started in the lumbar spine. It was a huge failure at that time with device migration and subsidence. So nobody used it. So now in 1989, in the UK, they designed the metal on metal stainless steel ball and socket design, but this socket was really deep. So it didn't allow any, it was not forgiving, didn't allow any change of axis of rotation in any plane. So that was also a failure. So they changed the design in after that, and they made bottom part it is shallow and ellipsoid saucer, so they can permit the translations and also give you 3 degrees of freedom of translation that allow the change of axis of rotation with the facet joint and the level above and level below. They also put locking mechanics for the screws as well. So immediately it was bought by the Medtronic and then it's called Prestige Disc, and it was approved in 2007 for single level by FDA after the clinical trial. But it was still bulky. A lot of patient has a dysphagia from it. So they changed the design again. So it's called Prestige LP. It was a titanium and ceramic composite with the titanium porous on the surface. There's a bony ingrowth. You can see on the top and bottom end plate, they have a keel, which also allowed some anchor in the end plates on the superior and inferior end plates. So it has a better stability. And then they has a metal on metal. So it's got approved for 1 level in 2014 after the extensive IDE trials. And then it's got approved for 2 level in 2016. So after that, on metal, we know that metal on metal, you have a metal debris and wear and tear. So Vincent and Brian developed in 1990 they are trying to make a disc as a look like a disc. So they make a metal on plastic. So the center core is a polyurethane core, which articulates with the 2 titanium end plates with the rough surface to allow for the bone growth. It's a really unconstrained device. It usually works with the press fit. So they approved for one level in 2009 after the extensive IDE investigation device with the trials. So now fast forward, after that, we started they developing a metal on poly. So the first metal on poly was a Pro Disc C was developed. And usually this is a cobalt chrome end plates with the titanium porous surface with the ultra high molecular weight polyethylene ball and socket joint. So, and then they allow keel to anchor the surface. But the problem with this device, they allow, it's actually allow some change in rotation, axis of rotation, but they didn't allow any translations. When you move a cervical spine, it's not only flexion extension, you allow 1 or 2 millimeter of translation in the sagittal and coronal plane. So it's approved in 2007. So they changed this design again. So they come up with the Secure C, Globus came up with the Secure C that has some translation, a 1 or 2 millimeter translation allowed on a sagittal plane. And then the Mobi C, it was developed by Zimmer. In this disc, they allow translations in a sagittal and coronal plane. So your poly can move forward and also in a coronal plane on top of axial rotations and the sagittal flexion extension and to pretty much make the same disc. So that's the most recent one in Mobi C. So after that, this is the most recent one developed by Orthofix is M6C. They want to make same as a natural disc. So they have a compressible artificial nucleus, which is polycarbonate urethane, and they have a fibrous annulus, which is made of polyethylene, and just try to mimic the same morphology and same biomechanics as whatever we have a natural disc. So this is actually approved in a pretty recently single level, but do not have a long-term outcome yet. So now this is all the disc. It's harder to get an MRI with the cobalt chrome around the disc and then look at the spinal cord in the future. So now they're trying to develop a more MRI compatible. I mean, all the discs are MRI compatible, but they're trying to avoid artifacts. So they develop in the peak end plate with ceramic nucleus now, which has a better MRI after once you have this disc scan, you can able to see all the spinal cord nerve roots around this. So it's approved for one, it's not approved yet in FDA, but they are still going an investigational device exemption trials at this point. So I think there's a lot of development in an FDA approved and in a disc replacement. These are the FDA approved implants at this point in the market available. One level, you have a 7 total discs. There are 2 discs with the metal model One disc is a polyurethane with metal and plastic, and there are 3 discs with the metal and poly. 2 discs actually approved for the 2 levels. One is Mobi-C, which is metal and poly, and one is Prestige LP, which is metal on metal. So now we have a long-term data, like comparing the ACDF 1 level versus 1 level disc arthroplasty. So we're gonna start with the metal on metal first. So they have this is a paper published 2 years after the trial. So at 2 years, there's no clinical difference in between the ACDF and a disc replacement. Only difference was the patient who had a CDA earlier returned to the work. And then there was a maintenance of the um, degree of motion is the 7 degrees at the 2 years of both the disc. They have a decrease in the index level surgeries at the 2 years. Mostly the index level surgeries are in a CDF is a pseudoarthrosis. You have to go back again and try to fuse that level again because we are trying to fuse that level. On a disc side, usually mostly the patient still has a kind of persistent radiculopathy needs like foraminectomy from the posterior side. So those are the reoperation on the index level. Reoperation at the adjacent level, at 2 years, there was no clinical difference between ACDF and the cervical disc arthroplasty. But you know what? It takes time to get the degeneration. So long-term data, we have Prestige ST has a 7-year and Prestige LP has a 10-year data now, comparing both the groups. So the clinical, there is for NDI, vascular, for neck pain and arm pain, the both group include they are significantly statistically difference between the preoperative and postoperatively in both the groups, except the NDI improvement was significant in the Prestige ST compared to the ACDF. The angular motions was still preserved at the 7 to 10 years, around 7 degrees at the disc level, which is pretty good. So we still have a motion there. The reoperation at the index level at the 10 years and 7 years is actually lower in the disc level, cervical disc arthroplasty compared to the ACDF. Reoperation at the adjacent level segment with the Prestige ST was lower than ACDF, but from Prestige LP, there was no statistical difference for the reoperation at the adjacent level, but it was lower in the disc replacement compared to ACDF. So now we just discussed with the metal with the 1 level. The brand disc is a metal and plastic, and they did it in 1 level as well. 2-year data was pretty much similar. The clinical outcomes are pretty comparable, except the NDI improvement was statistically significant in disc arthroplasty patients comparing to the ACDF. An earlier return to the work is with the CDA group compared to the ACDF. The angular motions are preserved at the 2 years around 8 degrees. Index level surgeries, there was no statistical difference between the index level surgeries of the brand disc and the ACDF. So 10-year data came out from the brand disc, and it's pretty much comparable with the clinical outcome with the ACDF and then the disc arthroplasty. In a matter of fact, is the NDI was improved more in the CDA group compared to the ACDF. The angular motion was preserved at 10 years, and then the adjacent level, there was no difference between adjacent level surgeries at the brand disc and versus the ACDF, but actually its numbers are lower in this disc arthroplasty patients compared to the ACDF. So that's metal on plastic. Now moving on to metal on poly. So we have 3 discs with metal on poly with the Pro Disc C, Mobi C, and Secure C. So we have a 2-year data and 7-year data as for all the discs. And then the 2-year data as for Pro Disc C is there is no difference in improvement in NDI, arm, and neck in both the groups. There was 10% of pseudoarthrosis rate in the ACDF group, so 10% didn't fuse, so they had to do the reoperation. Index level surgery is a little higher in the ACDF group than the cervical disc arthroplasty. So that's still consistent. The Secure C is about the same results at 2 years, and Mobi C has the same results at the 2 years as well, but they have a better NDI outcome at 6 weeks and 3 months. So earlier, the patient had a better outcome, but at the point of 2 years, both the outcome for ACDF and then disc arthroplasties are really comparable. The range of motion is still maintained at 2 years. Index level surgeries are lower in disc arthroplasty patients compared to ACDF. That's also same as all the disc. So now we are moving to the 7-year data for metal and poly. So ProDisc has same clinical outcome comparable to the ACDF. We maintain the range of motion at the 7 years is 8 degrees. The index level and adjacent level surgeries are lower in the disc arthroplasty compared to the ACDF. It's the same as Secure C as well. There was clinical results are comparable at 7 years. Lesser revision surgeries at the adjacent level and index level. They also look for adjacent level disease in the patients with the disc arthroplasty is 17% versus ACDF was 37%. So they are significantly lower adjacent level disease in a Secure C. So MobiC is the same. They look for its results are comparable. They have a maintained the range of motion and the flexion there. Index surgeries, reoperations at adjacent level and index levels are lower compared to the ACDF. But in this study, they also look for any radiographic degeneration at the adjacent level. And they found the cervical disc arthroplasty has a lesser than the ACDF for the superior and inferior adjacent level disease. So I think the MobiC and Secure C actually proven that adjacent level disease are lower in the disc arthroplasty compared to the ACDF on a long term. So this is the slide I made. I know it's a busy slide. It's a reoperation level at the index level at 2 year. So if you have to go back in and do the surgery at the same level at 2 years with all this disc replacement, you can see that disc replacement has a lower number to the ACDF, and that actually is met the statistical significant except one disc. Brand disc did not match the statistical difference between two, but the rest of the disc made really statistical difference between ACDA and ACDF patients. The lowest cervical disc arthroplasty was a MobiC was 1.2% at the index level. Now looking at the long-term data, the index level reoperation versus the adjacent level reoperation. I know it's a busy slide. There's all this disc is here with the 7-year, 10-year data. The index level surgeries are lower than the ACDF on all the disc. Adjacent level surgeries are lower in the disc replacement patients compared to the ACDF in all the studies and met the statistical difference, the lowest in the MobiC. I think the MobiC design actually helped to decrease the adjacent level disease because it allowed the translations in a sagittal and a coronal plane. So it's the lowest in the MobiC. So now moving to the 2-level ACDF versus the cervical disc arthroplasty. So there are only 2 discs is approved for 2-level. One is MobiC and one is a Prestige LP. Prestige LP is metal on metal and MobiC is metal on poly. So MobiC has a 2-year data. So it's improved in all the clinical aspect are comparable, but NDI success rate, that decrease in NDI numbers in the CDA group was statistically higher, and ASAP physical component score is also higher, statistically better in the CDA group compared to the ACDF. So now we are also look for over the period of time, the patients develop some bridging bond across the disc and then the level gets fused. So there is a level above and below is 10% getting to have bridging bond across the disc and they didn't have a motion there. So 2 years, that 10% disc become fused, but 90% time they're still moving. So they're maintaining the flexion extension and the lateral bending. While ACDF group, they have a 7.6% of pseudoarthrosis that needs reoperations. So So adjacent level radiographic degeneration was higher in the ACDF group compared to the CDA group for 2 levels. So MobiC has a 7-year trial. It shows the same thing. Has 11% has a bridging bone and loss of motion at the level of the disc replacement, but the range of motion was on the overall was maintained. Adjacent level radiographic degeneration was lower in the CDA, and then the overall clinic success was better with the CDA than the ACDF. It's the same with the Prestige LP. The only difference between Prestige LP and MobiC for 2 level is that somehow Prestige LP has a higher bridging level bonds across the disc and loss of motion. It happened on almost like a 36% in the inferior level versus 27% compared to 10% in MobiC. But it's still, overall, it was a better outcome, and then the comparable to the ACDF. If you look for 10-year data for 2 levels, they have a 39% patient actually breached the bond across the disc and lost motion, but 60% still has a motion, still has a better outcome overall. But I think the Prestige LP came in the market earlier, and people are still learning. Over the period of time, we know what to do intraoperatively to prevent the bridging bond across the disc. That was a problem with the Prestige LP. MobiC came in the market later. By that time, most of the people know technique better. So I think if we do nowadays, I won't say it's 39% is true at this point of time. So this is the reoperation level at the index level for 2-year data for disc arthroplasty and ACDF. So this is it's lower in the disc arthroplasty compared to the ACDF. And this is the reoperation rate at the index level and the adjacent level on a long term. So you can see an index level and the adjacent level is lower, is 4.4% versus 11.4 in the MobiC compared to Prestige LP. And then is also overall decrease in the CDA compared to the ACDF. So I think the reoperations are lower in the disc arthroplasty compared to the ACDF, both at the index level and adjacent level. All right, Matt, you want to take over?
So as Dr. Patel was going through, there's excellent summary there of the different implants, but as the use of the cervical disc replacement becomes more ubiquitous, we're seeing a rise in the proportion of CDR compared to single level ACDF as of 2017, 2018, accounting for a quarter of these procedures with multiple devices approved by the FDA. It's now vital for us to understand as practitioners how these devices are failing and how we are failing at these single level procedures. This paper out of Rush Group looked at their primary index patients with cervical disc replacement, as well as those who were referred to them for revision after an index procedure elsewhere. They sought to quantify and categorize the types of failure both in their own population as well as within the literature. Looking at these procedures, including 201 total levels between 2005 to 2020, they found, as similar to Dr. Patel mentioning, the revision rate of 4.7% without including HO. They broke it down into 6 kind of general categories. We have stenosis, migration, instability, motion loss due to the device, and then implantation error, including malposition and improper sizing, as well as wear with and without osteolysis. But they found it was similar both in their primary group as well as their literature review. Within these disc arthroplasty procedures, the single or the index level complications primarily consist of stenosis as the most common, and then migration and instability as the second most common. The redeeming factor of this is that you can often use an ACDF as salvage, but this does require another surgery. But what can we as surgeons do to be better about preventing this? And for that, I'll give it back to Dr. Patel.
So I think this discs are, sorry, yeah. This disc is present since 2007, so 6 is more than 10 years now. And then all the IDE study long-term data are comparable and it's better than ACDF. So if you had some, I think is important to understand the patient selection is most important, is utmost important. If you had a failure, I think is mostly because of clinical error and judgment. So I think indications are important. Is more important when not to do it than when to do it. As contraindications are really, really important. If you have an osteoporosis T-score less than 1.5, You have a cervical instability on the dynamic x-rays, has an angular kyphosis there. There is a compromised body from the index level at some point because of a trauma or something, or patient has a like tumor, like severe disc disc degeneration or facet disease. I think those are the indications. Sometimes that some disc is collapsed is really badly. You cannot do disc replacement and collapsed disc. At least you have to have at least 3 millimeters or more height preoperatively in order to do successful disc arthroplasty. So I think that the contraindications are important and the techniques are important how to do it. So I think is a discectomy is like, as usual, you have to do thorough meticulous discectomy. You have to preserve that bone plates. Preserve the anterior lip of the superior end plate is important as well. And bilateral wide foraminectomy and release. Even if you have one-sided foramina is compressed and we are doing surgery for unilateral symptoms in ACDF, yes, you're okay to do only one-side foraminectomy, but it's important to do bilateral foraminectomy when you do disc replacements. And then intradiscal parallel distraction, posterior release. I'm gonna go through all these points in the next slides. It's important, it's most important to take x-rays. It's important to take the x-rays preoperatively, position the patients, get perfect AP, perfect lateral x-rays is important. If you're not able to see the x-rays, you're not gonna able to do the disc replacement. It's because it's a pretty radiographic and dependent. You have to have a fluoro shots. So if your patient has more than 40 or 35 BMI, you're not gonna able to see C5, 6, and C6, 7 level intraoperatively. So those patients are not good to do the disc replacement. Caspar pin placement is important because you have to put the Caspar pins parallel to the end plate above and below. And also you have to put a little bit north and south in order to allow some room so you can use all the disc arthroplasty instruments through in between the Caspar pins. End plate preparations. I usually make sure you have end plate prepared very well. You do not leave the end plates intact. Do not bore on it. I usually do. So you can see this anterior lip on the top part. I preserved it just to make sure they have anatomical, all the end plate is preserved. I do not want to bore the posterior osteophyte. Try to take out as much as from Carrison so you don't have any bony bleeders, so that can cause any bridging across the disc. If you have any cancellous bone open, try to use a bone wax to cover it up, so that helps to prevent any bony bridging postoperatively. This is a parallel distraction. Take the Caspar pin before you put the disc, do the parallel distraction, release your Caspar pin distraction. And once you have parallel distraction, then you put the Caspar pin distraction again. Meticulous decompression is utmost important, wide decompression of the foramina, because most revision cases at index level after disc arthroplasty is a revision foraminectomy from the back. So try to achieve wide decompression from the front. Try to achieve both foramina wide open before you proceed with any kind of a disc replacement instrument inside. So wide meticulous decompression is utmost important. Trials are important. You have to make sure you get a perfect lateral and an AP x-rays when you put trial in. Do not over distract. You always look for the facet joint behind here. Do not over distract the facet joint. Start at the 5 millimeter height trial and go slowly up. Then you put the disc. Usually I put the disc in a lateral shots, and then at the end, once you're done with the disc placement, I usually compress this disc across the Caspar pin, so you can that the keel on the top and bottom has a better purchase and anchor into the end plates. And then you can take AP X-ray as well, just to make sure that you are right in the center of the disc, so your disc is better placed. And then try to use maximum width and depth of the disc. So you have to cover the entire end plate with your disc arthroplasty. So these are the things you have to keep in mind while doing a disc arthroplasty. So I have a case number one. I had a 33-year male patient with the neck pain on the right-sided arm pain. Failed as usual conservative treatment. This is what X-rays are. The MRI shows he had a 5-6 disc herniation, mostly on the right side, compressing on the nerve. This is what he has a flexion extension view at the 3 months. You can see that MOBC has some translation in sagittal view on a flexion, which is important because we naturally we do have some 1 or 2 millimeter translations on a sagittal plane. The second patient has a same scenario, had the C6-7 level, disc herniation, pain, 41-year-old, has an NDI of 72, which was improved at 3 months to 24%. WAS score was neck was 8, was improved to 3 at 3 months. WAS score was 7 at the arm pain and improved to 3 at 3 months. So this is the patient's preoperative X-ray. MRI showed the C6-7 disc herniation on the right side. And this is the X-rays in the postoperatively with the flexion and extension view. You can see on a flexion that MOBC allows some translation, 1 or 2 millimeters, which is important. So in summary, CDA means cervical disc arthroplasty is alternative treatment option, is not the replacement of ACDF. This is keep in mind, this is not the replacement, is alternative treatment. Cervical disc arthroplasty is better in certain patient population than ACDF. So patient selection and indications are utmost important when you consider for cervical disc arthroplasty to get a superior outcome than the ACDF. It's important to understand when not to do it. No significant difference in patient-reported clinical outcome on long-term data between ACDF and cervical disc arthroplasty at 1 level and 2 level. Lower rate of revision surgeries at the index level of cervical disc arthroplasty compared to ACDF at 7 to 10 years outcome. There's a lower rate of adjacent level surgery with the cervical disc arthroplasty versus ACDF at 7 to 10 years outcome. Thank you.
Thank you, Dr. Vincent and Dr. Patel. That was an excellent overview. We have about 10 minutes for questions. People can put them in the chat box or raise your hand, virtual hand, or just speak up. I'll start with a question. Watching this, all I can think about is the destruction that we occasionally see with adverse soft tissue, local soft tissue reactions from biologically active metal wear debris in hips, where you can see complete dissolution, necrosis of the abductors, for example, the hip capsule, all the surrounding soft tissues. And do you ever see anything like that with cervical disc arthroplasty? And could that be a potentially life-threatening complication given the structures that are around the cervical spine?
I mean, so far on the literature, I don't see that's reported yet. And then the good thing is about it is like the revision done at the index level is not because of the failure of the disc. Most of the time, they don't see too much subsidence. And the debris on the metal, they did some study to look at how much you can find metal on the blood level, which is actually extremely lower than a metal on hip. So far, I think we just have a 7 and 10 year data, so I can't speak for it, but I don't see anything which I would say is pretty badly returned, that the patient disc arthroplasty went out into the compressive cervical disc like spinal cord or something.
Maybe the different loads on cervical discs are somewhat protective compared to hip replacements.
Yes. Yeah, I think it's because we just have a 10 pounds or 20 pounds weight on top of the cervical spine on our head. Rest of, I think it doesn't take that much axial loading compared to what we are seeing in the hips.
Well, I don't see any other hints, so I'll ask one other question. Are there any limitations on activity with a cervical disc arthroplasty compared to an ACDF?
ACDF, you have to, my protocol is I give them a collar for 3 months, and then I tell them no pull, push, and lift more than 10 pounds, at least 3 months. For cervical disc arthroplasty, I'll give them a soft collar for just for comfort for 3 weeks. If they don't want to put a soft collar, I'm okay with it. They don't have to use it.
And how about long-term activities, sports and things like that?
That's actually not reported in literature. Like every surgeon is different, but I don't think it's a major issue. I would say they can go back, because initially this is all tried in military, the Prestige ST and LP. The studies are mostly done in military people, and they allow them back to work and they can do whatever they want. There was no restriction.
This question has kind of already been touched on in the last question, but this was a topical issue for NHL hockey fans this year, because Jack Eichel was a player for the Buffalo Sabres and had a cervical disc problem, and was advised by his doctor to get a cervical disc replacement, but the medical team refused, and the team actually forced him to trade, and so he went to the Las Vegas Knights and then got a cervical disc replacement, and he's returned to play this year. And now a second player for the Blackhawks has returned to play in the NHL with cervical disc replacement. Just wondering what your thoughts are about that. I know that just people have also, in European leagues and in, rugby and other contact sports, do you feel uncomfortable with people going back to high level contact sports like NHL hockey?
I don't think so. I'm okay with it as long as they're out of 6 months or something, and their end plates are incorporated with the bone on a CT scan or something, and then I'll let them go back to work. Go back to high contact sports, because then it's gonna be like completely same disc you had. It's just a different type. It's like, as long as it's incorporated to the end plate on your titanium and hydroxyapatite porous surface is bony in growth, is proven on CT scan at 6 months, I'm okay. They can do whatever they want.
That's really interesting, Dr. Patel, because also in the NFL, there are players that undergo single level fusions, and, they're actually asked, suggested that they retire. Not always, but certainly that happens. So this sounds like it may be a more durable solution.
I think it's Peyton Manning had a fusion done in C-spine, and he didn't retire. But he was a quarterback, so you're not going to take that much hit compared to the running back. I think it depends on their positions too.
Yeah.
But I think he stayed. You can see it, like when he got a hit, like he can do this. He had some numbness going there. I can see that on the TV, like, all right. So then like, yeah, he had some issue, but he was fine.
Fine, except he could hardly throw the ball, but yeah, that last year.
Yeah.
I don't see any other hands. Are there any other questions or comments? Any of the other spine surgeons have anything to add to this? Okay, well, yeah, that was really a wonderful overview for a topic that I suspect most of us do not know that much about. Thank you, and I'm glad you're starting to incorporate these into your practice. With that, I want to thank Dr. Cole and Dr. Bunzel for those great accolades for taking care of our patients. And I want to thank Dr. Vincent and Dr. Patel for this really wonderful grand rounds. I hope everybody has a great week. Thank you.
Thank you.